Finish up our discussion of antidepressants by taking a look at some potential new directions for treating depression and for understanding the causes of depression. So first, what I want to do is pick up where we left off. We talked about a whole class of drugs. We also saw that there were some side effects. And so what we really need is to think about what we need in terms of newer antidepressants. Obviously, we need to decrease the side effects. We want to try to get rid of sexual dysfunction as a potential side effect because that seems to be a particularly problematic side effect. Obviously, weight gain and sleep. These are probably the three most important side effects that we want to try to eliminate because they have the greatest effect on compliance with antidepressant treatment. We want to reduce any cognitive deficits from either drug treatment or from depression itself. If it's possible, try to have something with a faster onset, but given the neurogenesis theory of depression may not be possible, but certainly something we'd like. We would really like something that's efficacious in refractory patients, that is, patients that don't respond or that patients that go back into depression, and certainly we want to keep people in remission. So these are the goals of new antidepressant treatment. So let's look at some areas in which new research might be looking at how to treat depression. The first of these has to do with the serotonin transporter. And this is not my bad pun, it's one that came from your textbook. But the serotonin transporter captures the 5-HT molecules and transports them back into the terminal for recycling. Obviously, this is already the target of a great deal of the drugs that we've talked about. What we think is possible is that abnormal development of these transporters might predispose people to depression. Now, that might be due to genetics, it might be due to psychosocial stressors, it's hard to say. In humans, if we give people 8 days of a pretty high dose of citalopram, you get reduced serotonin transporter in the diencephalon and in the brainstem. So obviously it is having an effect on the transporters themselves. So what research in this area might lead to is therapies for antidepressant non-responders. So those people who aren't responding to our current class of antidepressants, by focusing more specifically on that serotonin transporter and its issues, are a potential way that we can explore treating depression in the future. Another area that we can look is glutamate. We haven't talked much about glutamate. It's more of a maintenance neurotransmitter. We'll talk about some of the areas where it comes up as an effective neurotransmitter, but the reason why it's potentially effective in treating depression is because it might be involved in neurogenesis. The first of these are what we call non-competitive NMDA antagonists. And we haven't talked much about the NMDA receptor. The NMDA receptor is a really important neuroreceptor we'll talk about when we talk about benzodiazepines. It's the N-methyl deaspartate receptor. Really important for learning and memory, and it's an important part of our brain functioning. Well, we can antagonize this particular receptor with drugs like ketamine or memantine. And ketamine is a tranquilizer. Well, it's a veterinary tranquilizer, but it's also a hallucinogen. It's a drug that's used in clubs a lot. And we'll talk about it later on in the semester. But it has been shown as a potential way to treat depression in a way that's different from the antidepressants we have available now. So it does have antidepressant action in animal models. In clinical trials of ketamine, there tends to be what we call a rebound antidepressant effect. And it might be what's called the glycine site is the one to work with on these NMDA antagonists. And so the thought is that you can give someone ketamine, and then after the drug wears off, they get a rebound antidepressant effect, so they don't have to constantly take a drug. Other glutamate receptors, the AMPA or kainate receptors, have been shown to have antidepressant actions in animal models, and they might be potential targets for antidepressants with no cognitive dysfunction as a side effect. So these are potential areas of research, and certainly there are a great deal of people working with ketamine as a drug for PTSD and for treating depression. Next, I want to talk about substance P, which is a peptide. We're going to talk about other peptides as well. but substance P is involved in pain relief. So the rationale for substance P as a depression target is that it is located in the central nervous system sites involved in stress. Acute and chronic stressors increase substance P. Chronic antidepressant treatments reduce substance P. We know depressed patients have elevated levels in plasma and cerebrospinal fluid. And so there is something in trial now, in clinical trials, targeting substance P as an antidepressant. So this may be the link between pain relief and antidepressant effects. And we're going to talk more about substance P when we talk about analgesics. So keep that in mind. It's a potential target for treating depression as well. To turn more specifically towards the peptides, we have to think about what the relationship between stress and depression is. And we've already talked a little bit about that stress seems to be involved in depression. And what happens is corticotrophin releasing factor is an important stress hormone. And we're going to take a look at what's called the HPA axis here in just a moment. But CRF is the driving force of the hypothalamic pituitary axis, or what we call the HPA. It was isolated in 1981. It's a 41 amino acid peptide. Neurons in the hypothalamus release CRF. CRF then stimulates release of ACTH from the pituitary gland into the bloodstream. It's a complicated set of effects. ACTH then travels through the bloodstream to the adrenal cortex and causes the release of cortisol, which is a glucocorticoid from the adrenal cortex, which are located atop your kidneys. And then cortisol is what activates the stress response. And in fact, cortisol is the primary stress hormone that we're going to be interested in. So let's take a look at this overall HPA axis functioning. Now, when I talked about neuroscience, one of the things I talked about was endocrinology and how the endocrine system is sort of the body's slow nervous system. Well, here's where it's going to come into play and why it's going to be important. So up in the brain, we have the hypothalamus, which releases corticotrophin releasing factor, which travels next door to the anterior pituitary, which causes the release of ACTH, which then travels down to the body to the adrenal glands located on top of the kidneys, which causes the release of cortisol, which then travels up to the brain and eventually causes CRF to stop being released and then shuts this whole system off. Well, what we think is happening is this negative feedback loop from hypothalamus to pituitary to adrenals back up to the brain. This negative feedback loop may be out of whack in depressed patients. So when someone experiences a stressful event, hypothalamus secretes CRH, causing the pituitary gland to release ACTH, which then causes the adrenal glands to release cortisol, which creates this negative feedback loop. When blood concentrations rise above a certain threshold, cortisol inhibits CRH secretion from the hypothalamus, which turns off the ACTH secretion, which then leads to turning off of cortisol and secretion from the adrenal gland. Complicated process. In depressed patients, this loop no longer works, resulting in excess production of corticotrophin releasing hormone or corticotrophin releasing factor, and hence eventually of cortisol. So many seriously depressed patients have very high levels of cortisol, and this is caused by chronic stress. Well, cortisol is really bad for the hippocampus in parts of the brain that are associated with cognitive loss and cognitive dysfunction in individuals with depression. So, targeting this system may be important for treating depressed patients. So here's the rationale. Depressed patients have hyperactive stress systems. If antidepressant treatment is successful, the system may no longer be hyperactive. So dampening the CRF response to stress may be a good treatment for mood and anxiety disorders. So therefore, a good antagonist might be an antidepressant. Mifepristone, or RU46, is actually a gonadotropin-releasing antagonist, which is a progesterone antagonist. This is the abortion pill. Obviously, that's a significant side effect. So we wouldn't want to be giving women this drug without some knowledge about its effects. But these related drugs might be a good target for treating this stress response. So obviously, if this research is going to be done, it needs to be done in males first to see how it affects the stress response. All of this has to do with that neurogenic theory of depression we talked about. Now, I want to talk a little bit about neurogenesis. and how a little bit about neurons, birth and survival of new neurons. And this clearly plays some role in the cause and treatment of depression. So we want to try to have a positive effect on neurogenesis. So what affects neurogenesis? Well, age, decreased serotonin, stress, use of opiates or methamphetamines decreases neurogenesis. So these are all things that are bad for generating neurons. Things that are good for neurogenesis include physical activity. Oddly enough, some caloric restriction, that is, not eating everything in sight, is potentially good for neurogenesis. In fact, there is some evidence that fasting on occasion is probably good for you. So that's something to keep in mind. An enriched environment, certainly in children, is associated with neurogenesis. Oddly, traumatic brain injury results in neurogenesis. Sometimes that neurogenesis is not good, but once the brain's been injured, it tries to rally and then regenerate those neurons. Ischemic insults, which are strokes, that sort of thing, can result in neurogenesis. Seizures also. In fact, seizures probably are the result of this factor gone awry. Estrogen and progesterone both are associated with neurogenesis in various places. Estrogen is certainly associated with neurogenesis in the hippocampus. Progesterone is associated with neurogenesis in the olfactory cortex, which is why pregnant women have such great senses of smell. Growth factors, increased serotonin, electroconvulsive therapy, all of these are associated with increasing neurogenesis. So keep in mind, hippocampal volume is decreased in depressed patients. We talked about that previously. One of the thoughts behind depression is that people with major depression have some impaired ability to cope with novelty, complexity, stress, and certainly some people, there are obviously a range of responses. Some people respond perfectly fine to a great deal of stress, and other people crumble in the sight of very little stress. And so there are a great deal of individual differences. And so it's possible that antidepressant medication might fix that problem. There may also be some effects in the prefrontal cortex, and certainly there are a great deal of connections between the prefrontal lobes and the hippocampus. These are the parts of the brain that are responsible for encoding and retrieving memories, storing memories. Our basic cognitive functions are all prefrontal hippocampal functions. And so treating the depression and the loss of neurons probably is going to be beneficial for treating those problems as well. So, like I said before, the hippocampus is clearly implicated in cognition, also implicated in the hypothalamic pituitary adrenal axis control, and seems to be involved in anxiety as well. When we talk about anti-anxiety drugs, we're going to talk about their effects on memory as well. So all of these things are related. The amygdala is involved in our primal emotions, fear particularly. Hippocampus is involved in learning, cognition, anxiety. Prefrontal cortex, working memory, cognition, and mood. So all of these brain areas are going to be very important for our understanding of depression. So understand this: stress kills your brain. It doesn't kill it, but it's bad for it. It's certainly involved in depression. It decreases neurogenesis and, in fact, increases neuronal death. About 50% of depressed patients have a dysfunctional hypothalamic pituitary adrenal regulation, usually associated with elevated cortisol. Activation of the APA axis with too much glucocorticoid for too long inhibits adult neurogenesis in the hippocampus. In fact, people with high levels of cortisol generally have reduced hippocampal volume, which has clearly got some problems and can certainly be associated with some difficulties. Antidepressants may actually protect the brain, increasing rates of new cell birth, increasing the number of neurons that survive. Antidepressant treatment also blocks the effect of stress, that is, it normalizes neurogenesis in the adult hippocampus. And these changes are consistent with the time course, that is, the delay of the antidepressant effect. One of the questions has always been, why do antidepressants take so long to take effect? Well, it may be due to the fact that what we have to do is wait for those neurons to grow, and etc. So, one of the things we want to think about when it comes to regulating this neurogenesis system is brain-derived neurotrophic factor, which we talked about previously. This may be useful in protecting our brain from being sort of chewed up by stress. So remember there's a relationship between brain-derived neurotrophic factor and CREB, which is that cyclic AMP substance we talked about earlier. And it's certainly involved in what we call synaptic plasticity. Synaptic plasticity refers to the fact that the connections between neurons and the life and health of neurons are all affected by plasticity. That is, our ability to learn, our ability to overcome injury, all has to do with plasticity. So learning and memory and neuronal development are all part of that, and brain-derived neurotrophic factor is an important part of that. So what's the evidence for the relationship between brain-derived neurotrophic factor and depression? Well, we do know that acute and chronic stress downregulates brain-derived neurotrophic factor. That is, the more stress we have, the less BDNF we have. We know that corticosterone or cortisol decreases brain-derived neurofactor expression, so that may be one of the reasons why cortisol results in neuronal death and certainly less neurogenesis. Chronic antidepressants, that is long-term antidepressant use, increases brain-derived neurotrophic factor expression in rat brains, so it's possible that that might be true in humans as well. Unfortunately, the time course is not exactly the same as the clinical delay, but I know we're trying to figure this all out. And importantly, other psychotropics do not have any effect on BDNF, and so antidepressants really seem to be tied in with brain-derived neurotrophic factor. So this neurogenesis hypothesis seems to have some pretty solid legs to it. There are some limitations, however, to the relationship between depression and BDNF. There's no direct evidence that loss of endogenous BDNF or reduced BDNF signaling produces depression or impairs the effects of antidepressants. And so there might be some intermediary step involved. Not all studies show antidepressant upregulation of BDNF. That is, not all studies show that antidepressants are going to increase brain-derived neurotrophic factor or improved brain-derived neurotrophic factor functioning. And there are different effects of brain-derived neurotrophic factor in different brain areas. And so there may be a specific type of BDNF or some other neurotransmitter involved in this that has to do with depression and neurogenesis that's also related to BDNF. These are basically, at their core, correlational studies. So cortisol is correlated with depression. Now, is the cortisol causing the depression or is the depression causing the cortisol? We don't know. Neurogenesis is obviously associated with depression. Is the depression causing the reduced neurogenesis, or is the reduced neurogenesis causing the depression? And so trying to tease all this apart is going to be very important. So what I want you to take home from all that is that the neurogenesis hypothesis is probably a pretty good one, but it's not directly associated with things like BDNF. So trying to figure out the intermediate steps involved is going to be important. Okay, so I want to turn now and talk to you about a couple of over-the-counter supplements that are supposedly good treatments for depression. And I say supposedly because, well, they probably really aren't. The first of these is Dehydroepiandrosterone, or DHEA. And this is a substance I have done a great deal of work with. I have 2 published papers involving DHEA. It's a glucocorticoid hormone that is sold as a food supplement. It's a precursor to estrogen and testosterone. It's produced by the adrenal cortex as well. It's a weak androgen. Our DHEA levels peak in our early to mid-20s and then steadily decline by about 90% by the time we reach age 70. There is some belief that DHEA might be involved in cognitive aging. Certainly, hormones are associated with a variety of cognitive processes and functions, and we're going to talk about those later in the semester. DHEA actually metabolizes into testosterones and estrogens, depending on whether you're a male or female, and depending on your body composition. So it can be useful in boosting those. Unfortunately, you won't know if your body's going to turn it into testosterone or estrogen, and there are certainly some risks involved. So taking it might delay aging. There is some evidence that it improves mood and might delay age-related loss of memory. There are no long-term studies. I can tell you from our studies, the evidence is mixed. With postmenopausal women, there is some benefit potentially for things like longer-term memory, but no benefits for shorter-term memory. Possibly some benefits for things like visual spatial ability. But the evidence is kind of mixed on that. So I can't wholeheartedly support it, but I also can't deny it. And I certainly know a number of people who find that it does improve their mood. Certainly in perimenopausal women, people that are at the onset of menopause, this might be a good supplement to boost estrogen levels as they're losing their natural estrogen levels. So there is certainly something to that. We're going to take a closer look at DHEA later in the semester. But right now we're interested in its effect on depression. There are two studies of its effect on depression, dysthymia and cognitive functioning, and they did show meaningful improvements on mood that were comparable to standard agents. So it might be a good, safe way to treat depression. In particular, this might be a good use for postpartum depression or treating pregnant women for depression, because it's fairly natural and it's probably not going to, it's certainly not going to have the strong effects that an SSRI would. So it's certainly, for a depressed patient, a potentially good use. So if we look at DHEA versus placebo, we do get significant reductions in depression scales compared to placebo. So in elderly males, there is some effect, but seems to be transient. There is some evidence for a positive effect on mood in patients with HIV and AIDS. The effects there seem to be related to the ratio between DHEA and cortisol. That is, it seems to mitigate the effects of cortisol. There are minimal effects in postmenopausal women with fibromyalgia. It seems to be effective in midlife onset minor and major depression, but the results and the cognitive effects are fairly mixed. So it's a mixed bag, and certainly nothing I would ever take without talking to my physician first. So then the last of these is called SAMe, and the first thing to keep in mind is that some of these products, according to some sources, had no SAMe in them and had no evidence of absorption or effect. The biggest problem with over-the-counter supplements is there's no control. So with DHEA even, you don't know if you're getting even any DHEA or how much you're getting. So it's important to keep that in mind. So SAMe is readily formed in the body and transformed to homocysteine. The oral formulation is said to be a mood enhancer. Only about 1% of drugs are absorbed orally. And again, there's a wide variety in potency. So while you might see this for sale, given the very low absorption rates, it's probably not effective. Well, it's going to conclude our discussion of antidepressants. Obviously, there are a wide variety of drugs used for treating depression, but we have a long way to go before we fully understand what depression is and what's causing it, and really what we need to do to solve the problems with depression. Thanks, and up next, bipolar disorder.